Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
And good morning, everyone. This is another edition of Health Law Talk here at the Shahardy Sherman Law Firm. Conrad Meyer, Rory Bellina, two well-versed healthcare attorneys here. And also today, a special guest in the studio, Dr. Alice Hoyt. Hi, Doctor.
Good morning, Conrad. How are you? Good morning, Rory.
Morning.
Good to have you in. And I think today it's a special day that you're here. We really thank you for coming into the studio with us this morning. And we thought today would be all about you and sort of figuring out what sort of doctor are you, what's going on in your personal private practice, and a little bit more about your advocacy background. So
absolutely.
So to start off with, give the listeners an idea. You know, what is, you said you told me earlier you're a pediatric food allergist.
And adult.
So correct me. Thank you.
Yes.
So tell me a little bit about your practice and your background.
Absolutely.
And so the listeners can know.
So I am a Louisiana girl, born and raised in South Louisiana. And I'm a board-certified allergist immunologist, also board-certified in internal medicine and in pediatrics. And I focus my clinical practice on food allergy. I've been doing this for years now. Prior to opening my practice here in Metairie, I was at the Cleveland Clinic, and prior to that, I was at Vanderbilt University. So have really been blessed to work at amazing institutions, and was just so excited to come back down to my home state, very close to my hometown, and open up a practice where I felt I could best serve patients.
That's great. I mean, you got some good background. I mean, Cleveland Clinic, very well recognized background. And so when you talk about food allergy, I remember growing up, and I even asked you this question. I remember growing up, nobody when I was my age talked about food allergy, and I'm not young anymore, but I don't remember, everyone freaking out or saying, no, we can't cook this or can't bring that ever. So tell me, how did this develop?
Well, it wasn't talked about then because it wasn't being diagnosed then is one thing, but also it was not occurring then. Anaphylaxis, meaning an immediate onset of hives, swelling, trouble breathing, vomiting, that's anaphylaxis. Mm-hmm. That's hard to miss. And so I don't think that we're missing the diagnosis. It is that it was not happening as much, and it is happening much, much more now. Why? We don't know. We don't know why more and more, especially children, are developing food allergies.
That's interesting because I know I used to think to myself, is this just helicopter parents? Is this just over anxious children? Or even adults? Is there something wrong, or is there really such a thing as a food allergy?
There absolutely is, and I do remember our journey on this road, Conrad, because you've been helping my nonprofit organization for years now, and it's been interesting. I don't think I've ever told you this, but I think it's been interesting to watch your level of knowledge, and specifically regarding food allergy and policy, that really grow and expand. And I remember one day I was on the phone with you and you're like, what? Like, this is really happening? It was something about stock epinephrine, which I know we'll get to.
Right.
But it's just, yes, it is happening more and more. What is interesting is called the hygiene hypothesis. And that's the whole concept that we're all too hygienic now. And what's interesting about food allergy is that the allergic antibodies that participate in allergic reactions, they're also used to help keep us safe from parasite infections. Mm-hmm. I say that because in third world countries where they don't really have food allergy, but they have parasite infections, it's sort of the same immune mechanisms that are associated with food allergy. Whereas here, we don't really have parasite infections. We have plenty of food allergy. So just food for thought.
So what I guess the most common one that you and I have even discussed it, peanuts. Mm-hmm. Would you say that is probably the most common food allergy, or do you think maybe a top three? I don't know. Top three? I don't know.
So now we have a top 9.
You have top 9.
Top 9.
Wow.
Sesame seed is really coming in there with a strong
Sesame seed.
Oh yes.
Wait,
yes.
like raw sesame or like roasted sesame? Or does it matter?
Excellent question. Studies have shown that in peanuts in particular, and that was done at work here, Sohail and Malachi, that roasting peanuts actually makes them more allergenic. We think it has to do with the way the sugars and the proteins
they break down, and then the oils come out when you roast it. I mean, is it?
So it's called a Maillard effect. It's that nice toast, like when you put toast in, you put bread in the toaster, it makes toast. It's nice and brown and warm and like yummy smelling.
I like that.
That's called the Maillard effect, and something about that makes the protein more allergenic. Clinical pearl number 1 here. What you're allergic to, if you're allergic to a food, is actually the protein. So foods are made of carbohydrate, protein, fat, or alcohol. Right. The allergen is a protein. And so clinical pearl number 2, Conrad, you mentioned oils. Most people who have a food allergy, they can actually eat at Chick-fil-A that fries in highly refined peanut oil, because highly refined peanut oil is highly refined, meaning there's no peanut protein in it. It's just oil, and oil is not the allergen.
Interesting. Mm-hmm. I really had no idea. Did you know that, Rory?
I did not. No, and I want to get back to the peanut part, because I was just having this conversation with another parent the other day at our kid's school, and the topic of it's a peanut-free school and the peanut allergies. That topic was what we were discussing. What's your can you go through what's the history of that? Because I honestly didn't know, and when I talked to it with older people or my parents or my in-laws, you know, they'll say, "Oh, well, we didn't have that. Kids ate peanuts; they were fine." But like you mentioned, there seems to have been this big shift to where, you know, now most schools, I think, are peanut free. Kind of, where did that come from, and kind of what are your thoughts on that? Because I'm curious about that, just on a personal basis.
Absolutely. So first, let me clarify for our audience the top 9 food allergens: peanut, tree nuts, egg, milk, wheat, soy, finned fish, crustacean shellfish, and now sesame seed. So in 2023, you're going to begin seeing sesame seed on your nutrition labels if it's an allergen, highlighting that it's an allergen. Regarding peanut-free schools, that is a very, very hot button issue. And the Journal of Allergy Clinical Immunology published an article at the end of 2021, and my colleague and I actually wrote a response to the article, and that was also published in the Journal of Allergy and Clinical Immunology. And it was all about food allergy reaction prevention and management in schools and early learning centers. They reviewed all of the evidence that we have from how to manage food allergy effectively in schools and early learning centers like daycares, preschools, and all of their recommendations, they ended up all being conditional recommendations for a few reasons, meaning we don't have a whole lot of evidence as to whether or not to make this particular policy regarding food allergy in school. And the evidence we do have is all kind of like, not great. So our response to the article was like, this is a fantastic article, but one thing that they really didn't highlight was the importance of having an allergist, a board-certified allergist, involved with schools to help schools make evidence-based, informed policies that meet the school's culture. So for a preschool, you're going to have different policies in place regarding food than you would for a high school.
Right.
But if you're trying to take a sort of a cookie-cutter approach of, well, we all have to do this, fill in the blank XYZ policy, that is not, you're doing a disservice really to the students as well.
And that's what I've seen, and we were discussing the conversation I was having with the other parent was that it's a archdiocese policy or whatever district you're in. It's just their policy. So, you know, instead of going on a school by school basis, I think they just made it a blanket policy for all of their schools, and it may or may not affect the individual schools, but now every child in the whole district, whatever it is, it affects them.
I want to know one thing. I mean, I want to know how many whether it's the archdiocese here in New Orleans or the schools themselves, how many of them have a board certified allergist actually advising them? I would fair to say none. I mean, honestly, I don't see that happening. I mean, in your practice, Dr. Hoyt, when you meet with schools or you talk to the administrators, do you find that it's more non-clinical people who are making these policies? Do they even get the advice of physicians? And if they do get the advice of physicians, are they really physicians that should be giving that advice?
That's an excellent point. And Roy, let me go back to your question too about
lots of questions here,
because I didn't answer your question about the thought of peanut-free schools. There's actually not evidence that peanut-free schools actually prevent allergic reactions. It's sort of a false sense of security, to be quite honest. But what there is a little bit of evidence for maybe is if you have targeted allergy zones that are very much age appropriate. And that comes back to my point about having policies that are appropriate for a child's age. Pre-K is going to be different than a high school. So should schools be peanut-free? We don't have evidence that says that that's helpful.
And is it harmful if they are peanut-free? Is there any harm to not exposing your kids to, I think what's happened to me personally, I have 3 kids all at the same school, and they can't have peanuts at all in the school. So, and they typically don't choose to eat it on the weekend. So essentially they're not eating peanuts, or they're not eating certain types of food. Are there any harms to that?
You can't even, like from the school standpoint, and at least in my kid's school, you can't even bring stuff to school that was baked, cooked, put together, where there was peanuts even around.
Yeah. Yeah, I know at the beginning of the year, I think most of us get that form of, check your labels, and if it's in a factory where peanuts were mixed,
can't bring it.
Yeah, what are the harms to that? I see you're smiling. No one can see that.
It's so interesting that you're bringing up like made in a factory. There's very limited. There are very specific regulations regarding how to label foods, and regarding allergens. Food allergens need to be labeled one of 2 ways. The allergen needs to be highlighted within the ingredients list, or right below that where it will say contains, and it'll list one of the if peanuts in there, it'll list peanuts. So that makes it easier for us to see what's actually in the food label, or the nutrition facts label. But all these other things like made in a factory or whatever, like none of that's regulated. That's all whatever a company wants to put on their label to, cover their behinds.
Now, are there any downfalls to not exposing kids to peanuts, or essentially that again goes back to my thing? My kids don't eat peanuts because they're not eating at school, and they don't request a peanut butter and jelly on the weekends, so they're really not getting it. I guess we're limiting that, so if they grow up and hopefully go off to college and they eat a peanut butter and jelly sandwich, what are the effects of something like that, of not being exposed to a certain food or ingredient or allergen protein, as you mentioned, for essentially until most high schools have the prohibition as well. And then you go off to college and you have a peanut butter and jelly sandwich. Are there any?
So we know that exposure develops tolerance. And what that means is that your immune system will see a food and recognize it as like, okay, this is fine. This is totally cool. Clinical pearl number 3, do not order food allergy testing online, because it's just going to be silly IgG testing, which is not allergic antibody testing. IgG is an antibody that simply says that your body's been exposed to something. It doesn't necessarily say much more than that. It doesn't say much more than that regarding food allergy. So the concept of having children avoid foods, we know that can promote the development of allergy, or what I really should say, the loss of tolerance. Okay.
So when they do have that peanut butter and jelly sandwich, if they would have had a reaction at 3, 4, 5, and maybe would have had to come see you or need some sort of treatment or some sort of protocol, when they have it now at 16, 17, 18, that they could have a much bigger reaction or response to it.
That we do know that our teenagers, our adolescents, our young 20s, they are at risk for worse outcomes. And there are a few different reasons for that. One, some people say that, they have worse decision-making skills, risky behaviors. Also, clinical pearl, number 4, alcohol will actually lower your threshold to have an allergic reaction. So that's something that's really important to talk to your college-age kids about who have food allergy is, if you're at a party and you're drinking and your decision-making is being further impaired, then you're at risk of accidentally ingesting your allergen. And then, because you're ingesting it with alcohol, you could potentially have a worse reaction or more likely to have a reaction. Also, if you look at the immune system of an adolescent, I mean, there's a reason, like going back into biblical times, that those were the people that were fighting and they think they're invincible, right? And their immune system does too. The immune system is a boss at that time of life. And unfortunately, what's happening when someone's having anaphylaxis is that their immune system is going rogue. It's seeing something and it is attacking it, thinking that it is trying to fight this bad guy, basically. But it really is the immune system going rogue. And so that is why another reason that I do think that is a risk factor that I like to consider when I'm thinking about risk for our adolescents and our young 20s kids. Now, the concept of you avoid a food, you're at risk of developing a food allergy, and I'll come back to that. And then is your reaction going to be worse later on? We think it could be worse just because you're no longer a little kid with a immature immune system. You're an adolescent with that boss immune system that I talked about.
So I'm sure it's hard to make a recommendation, a broad recommendation. It's probably more case by case or child by child specific. But what's your kind of general rule? Should you allow your children to eat these when they're home, or kind of under your supervision? Should you encourage them to eat the allergens, like you said, the crustaceans or the peanuts?
No, I can absolutely make very strong recommendations.
Okay, that's what I want.
Absolutely. So we do know, based on evidence, based on studies, that children under the age of 1 who have egg allergy and or severe eczema, they are at risk of developing peanut allergy. So there are some risk factors to developing a food allergy. How you know a 4-month-old has an egg allergy? We could get into the details of the recommendations, but the recommendations are very good because of the guidelines and of the evidence, because they do help us identify children who are at risk of developing a food allergy. I had a kiddo the other day who had never had peanut before, is a baby, has some pretty rough eczema. Mom was concerned about a different food. I was concerned about peanut because I knew that having severe eczema puts a child at risk of having peanut allergy. Did the blood work and very, very strongly suggests peanut allergy. So if you listen to my podcast, then you'll hear, oh, Dr. Hoyt, you always say you have to do a food challenge to really confirm they're allergic and don't just go on the blood work. That is very true. However, we are getting better and better with our testing, and allergy testing in the hands of a skilled board-certified allergist can be very, very helpful for your child. And so we know there are a few very specific tests that we can order to help us determine whether or not we think your kiddo actually is allergic specifically to peanut, so that then we can make an informed recommendation, such as avoid peanut, and also consider what's called oral immunotherapy, which is when we teach the immune system to grow that tolerance.
So let me ask you this. So you mentioned this just a moment ago about what you do, what the plan is, and I'd like to segue into that. So you recently opened up a new practice in Old Metairie, in Metairie. Is that right?
Yes.
Can you tell us and the listeners about your practice and the name of it and how that came to be, and go into a little bit? I'd like you to tell everyone, why is it that your practice is different?
Absolutely. So the name of the practice is Hoyt Institute of Food Allergy, and we provide evidence-based, family-focused information about food allergy to our families. Why I think we're different is because of the people who work at our institute, not so much including me. What I do is I provide you the most up-to-date, evidence-based approach to understanding what's going on with your child's food allergy, making a diagnosis. So many people are walking around with a misdiagnosis. So I clarify the diagnosis, what foods you really are allergic to. So many people think they're allergic to all tree nuts. Most people are not allergic to all tree nuts. In fact, a lot of things that are labeled tree nuts are not even technically tree nuts. Again, I could go on a tangent about that, Rory. But I will get you a diagnosis,
right,
and then provide you a treatment plan. Typically, the treatment plan for a food allergy is to avoid the food. That's always a great plan, but we can also do what's called oral immunotherapy, which is when we teach the immune system to tolerate the food. But I mean, other allergists can do that, and they do it very well. Many of them do. But what's really unique about my practice is that I have on board an excellent therapist who helps our families identify stressors, provide strategies for overcoming those stressors. Because food allergy, it's a 24/7. It's a 24/7 problem where you're sending your kiddo to school, and in addition to all the other things you worry about when you send your child to school, you're worried that they're not going to come home because they accidentally ingested their allergen, right? I mean, like, my child does not have food allergy, thank the Lord, and I worry about so many things with her. I can't imagine having to worry about that too.
Right.
And so having Melissa on board, she's just fantastic. And I mean, she helps with things like bath time, making that less stressful so that your oral immunotherapy dosing, you're less likely to, just all of these things.
And so Melissa, she is a licensed social worker, therapist that works. So you have a multidisciplinary team,
Yes.
and you take this multidisciplinary approach that I don't think I've seen any other allergist do that before. So that's very, very unique. And so she walks with, excuse me, she works with you to sort of, you do the clinical aspect on the allergy side, and she manages the therapy side for the families.
Right, because I could be recommending a treatment plan, but
Right.
if that treatment plan has particular stressors in it for the family, we're not going to have success. And so I need that other component, that social emotional support component, to help the family have the outcome, achieve the goals that the family wants to achieve. The other person I have to mention is Alexis, who's our comprehensive care navigator. I don't know if y'all have ever tried to call your doctor, but it can be very difficult to get in touch with your physician. At Hoyt Institute, when you make that phone call, you are talking to Alexis. Alexis is our care navigator. She and I are in constant communication. I'm shocked she hasn't texted me during this podcast, but she will help with your whole experience, making sure we get records, if in all of that. Like, when people call us, we take you in as part of our family.
And I'd love to know a little bit more about your practice as well, because I'm thinking of it for personal reasons for one of my children. But, typically, who are the patients that come to see you? What are the issues that they come and they say, Dr. Hoyt, here's what's been going on? And kind of what's that patient population for you look like?
A lot of it is younger families who have children who are younger age, who have food allergies. They've been told, like, oh, well, there's nothing really to do. You just have to avoid the food. Yet they go online and read reputable resources and find, oh, well, what's this thing called oral immunotherapy, and why can't my child do that? And that's what I do. That's what I specialize in. When I was at Cleveland Clinic, I helped build the Food Allergy Center of Excellence up there. And so this is what I do. It's hard if you're a board certified allergist who also does all these other very important disease processes to also do the type of food allergy management, this very detailed type of practice that I described, that I think is really important for a family to have the comprehensive experience and care that they need. And so it's a lot of younger families who want to do something about their child's food allergy. We also have some kids who are about to go off to college, and their families are kind of like, we're concerned because we do hear these stories. We work with a group in Ohio whose daughter passed away at college of anaphylaxis. And so it's really families who are informed. Food allergy families are so informed. They're informed. They know there's potentially a treatment out there for their child, and they want to know more about it.
Okay. And when these families come in, it's typically a sit-down conversation, and then, or where do things go from there? From testing, or can you kind of go into what happens after that or during that initial consult?
Yeah, so my initial consultation is actually 2 parts. And so when you call to schedule an appointment, Alexis is going to schedule you for the first day, and then a week or 2 later, the follow-up to it. The most important thing is I sit down and talk with you. Alexis is right there with me. She does helps a lot with documentation so that I'm not, who likes to be sitting there talking to their doctor and their doctor's literally like typing it into a computer? I hate that. And so I don't do that. I sit down and I talk to my patients. That's also where I'm able to see their cues. And I can see when a mom is stressed about something and a dad is stressed about something, and the dynamic that's going on there, because all of that goes into how successful could oral immunotherapy be? Or what is really going on? What is that anxiety level? Because then I'll talk to Melissa about it. Melissa will pick up on that so that we can really help the family. But we do the initial discussion, what has happened with your child, what symptoms, how long after, all of the clinical questions. I'll do skin testing if that hasn't already been done. A lot of allergists are referring their patients to me. And so if we need to do skin testing, we'll do that. If I need to order specialized blood testing, which many times I do, then we'll order that at that visit. And that's why they come back a couple weeks later, so that we have all of the information then when they come back to make a decision about what do I really think is going on. Do we need to do an ingestion challenge, meaning you and your kiddo will come back and we'll do incrementally increasing amounts of the food to determine whether or not we think you're allergic, depending on what your testing is and what your history shows. Or do we need to decide on the avoidance pathway or the oral immunotherapy pathway?
Okay. That sounds great. I was curious, kind of where that transgression went. As far as your practice, I know we want to jump over into your nonprofit and everything on that side. As far as your practice goes, are you taking insurance? Are you private pay? Kind of, because I know our listeners, especially the local ones, are going to have questions about that. How are you set up for that?
So we're direct pay.
Okay.
We will help families submit what's called a super bill, which is a horrible name, but we'll provide itemized overview of
Sure.
services and fees. But ultimately, I answer to my patients.
Sure.
If I'm getting paid by an insurance company, and this is just my own personal approach to it, and not all physicians can practice this way, but I set up Hoyt Institute, so I'm going to practice the way I feel that I am called to practice. I am going to answer to the family. So it's the family who, at the end of the day, is going to be writing the check to the institute.
Sure. And I think Conrad and I are starting to see that. I know one of our more recent podcasts was
direct pay primary care,
shifting to that model, and it seems it's so exciting and impressive. And as the cost of insurance just continues to skyrocket, just on your premiums and then your deductibles are even higher and copays. I mean, it's really becoming a question of is it absent a car accident or traumatic type of surgery that we need, do we really need these huge insurance policies? Or, I think a lot of people are opting to go this route.
Well, look at the difference. How many times have we witnessed in our practice where we walked in and the doctor's got the kiosk there and he's not even looking at you. He's just typing in
directly.
Right.
Directly into Epic as you're talking, because he's not going to get paid for documentation. Yeah.
Right. So, to be able to spend time with your patients, Dr. Hoyt, and listen.
Absolutely worth it.
I tell you this, I give my own family, my mother and my father went to MD VIP recently. And my mother was just like, I never knew healthcare was like this. This tells you that when they sit down with their doctor, just like you're doing, Dr. Hoyt, and spending the time with your patients and listening and talking, this is why you got into medicine.
Mm-hmm. That's exactly right.
This is why you did this, So,
yeah.
So I'm very happy to hear that. And so, let me ask you this. I know you're recently started.
Mm-hmm.
How has the reaction been? Tell me. I know when you open your doors, it's kind of like, okay, if we build it, will they come?
Right.
Have they come?
Yes.
So let's talk about that.
Yeah, and I'd love to hear, like you mentioned, exactly to segue on Conrad's question.
Right.
Have they come, and how have they reacted to this payment model? Because it's not new, but it's somewhat new.
But also the approach you're doing, because that's different.
Mm-hmm.
The approach you're doing is different. The payment model is different. Your marketing and everything you're doing is different. Mm-hmm. And so I'm curious. Now we're kind of getting into halfway to Q1, Q2, 2022. Mm-hmm. How's it been?
It's been great. We're a lot of word of mouth from pediatricians and from my allergy colleagues, which has been really awesome. And I ask Alexis that all the time, because Alexis is the one that talks through the payment plans and all of that stuff with
right.
the families, so that I don't have to be so directly a part of that. I think it just makes it more comfortable for everybody.
Well, break it down for me. And so how are your first off, you're getting patients, obviously.
Yes.
You're doing the doors open, people are
yes.
coming in, and it's expanding exponentially. Mm-hmm. Well, how do the patients feel both on the issue of your payment model And then on the multidisciplinary approach?
The latter is very easy to answer. They seem very happy. I'll ask them all the time, what do you think about Melissa? What do you think about Alexis? How is this going? They're like, we love them. We love them. And Alexis has so much sort of like FaceTime with them regarding texting, because they can text her. They have a question about an appointment, they just text her and they get their response.
Wow. Wow.
That's new in itself.
You know?
That's right. How often do you get that? I don't.
Unless they're a client, I'm not getting their cell phone.
They don't respond unless you're.
No, and so regarding the payment, I always ask Alexis, has there been any pushback? And it sounds like there hasn't been much pushback. I mean, we're staying pretty busy. We get paid, and my patients seem happy. And I always provide my information, and nobody abuses it.
Right.
I mean,
well, you set this
I probably
up.
call and bother them more than.
Well, what I'm saying is, you've set this up. I don't mean to interrupt you, but
No,
you set this up, and basically you've created your own concierge practice without the need for any service, without the need for any kind of overlay from another company. You've done it, boots on the ground, grassroots, and it's working.
Yes, and you know exactly how boots on the ground I've done it, because you helped me with how many EMRs did we look at, Conrad?
We looked at quite a few.
And ultimately, I did not go with any of them.
That's exactly right.
But no, I mean, it's been an amazing experience. We do, I really have a commitment that any child that walks through our door that needs our help, we're going to help them.
Right.
So however we need to make that happen, we're going to make that happen.
Interesting.
There's so much we can do regarding food allergy.
Well,
it's just time
let's
for us
pivot
to do
that.
Yeah.
Now let's go to the advocacy part. So
Okay,
can you tell the listeners a little bit about Dr. Hoyt, the advocate?
Yeah, so I've always been interested in helping schools, helping kids who need extra help. I came from a family that I was very blessed to have my amazing parents. They're one of the reasons I moved back, and just to always be told, get your education, and just I have been so blessed, and so I've always wanted to give back to others who have not had that,
right.
Especially children. And even when I was here in med school, I was a Schweitzer Fellow, and I did my fellowship teaching a nutrition class to Langston Hughes K through 3 students. So it's always been something. Working with schools has always been a passion of mine. When I was in allergy fellowship, I recognized that schools are not prepared for medical emergencies. And having done internal medicine and pediatrics, I ran way too many codes. And I knew just how effective having closed-loop communication, assigned roles when you're responding to a medical emergency, how effective that is. But schools didn't have a way to know any of that, right? So we started Code ANA. Code ANA equips schools to be prepared for medical emergencies like anaphylaxis. One of the biggest things we do is we really help schools obtain epinephrine autoinjectors, know how to use them. That's a big thing. You can have a tool, but if you know how to use it, then that's no good. But then also the bigger underlying thing is help them develop and implement their own medical emergency response plan and team.
So I'm going to ask a question that I already know the answer to, but our listeners may not. So, and I'm sure this also might vary on a state-by-state basis, but what's the current kind of procedure for a school if they want to have, and I'm thinking of my school in particular, the policy is if they're going to hold and potentially use the injector, you have to have a doctor's note, you have to provide it, it can't be expired, only X, Y, and Z people can do it. That's kind of it. But what is the general policy if a school just wants to have them on hand for a kid that doesn't know that they're going to have a reaction? Kind of what's the, and I'm sure that there's obviously liabilities involved with that, but kind of can you go through what's the state right now for schools that want to have these injectors or that are considering it but might not know what the policy is?
Absolutely. So what you're describing is called stock epinephrine. Stock epinephrine is epinephrine typically in the form of an autoinjector that's prescribed to an entity, whether it be a school, a business. It's prescribed to that entity to be used during an anaphylactic emergency, whether somebody has a known diagnosis and doesn't have their autoinjector, or they're one of the kids who has their first reaction at school. That is stock epinephrine. That is different regarding legislation and regulations than epinephrine that's prescribed to a student. And so we can talk about that later.
Sure.
Regarding stock epinephrine, there is the heterogeneity of stock epinephrine legislation in this country is amazing. 49 states have stock epi legislation. Hawaii does not, meaning they do not have protection for a school or non-school entity to have their own epinephrine autoinjector. And you made a very interesting comment. You commented on liability. And so many times schools that do not have stock epi, they are concerned about liability. But I think when we do this podcast in 10 years, maybe even 5 years, it will be perceived as more of a liability to not have stock epinephrine.
Right. I'm sure there's liability on both sides of having it and injecting it wrong, or injecting it to a child that wasn't having a reaction, or not having it and something terrible goes wrong. So I think, like you mentioned, there's liability on both sides. But let's take Louisiana, for example, because I think most of our listeners are here. What's the policy for a school or a business? If school is probably the best example, but a school or a business, if they want to have this on hand, is it similar to kind of the process of an AED, where you just get it and you get a little bit of training, and if you need to use it, or is it totally different?
Every state is different. Here in Louisiana, we have stock epi legislation for K through 12 schools. It is permitted. It is not mandated. When we look at the 49 states that have stock epi legislation, some of them, those 49 states, mandate that schools have stock epinephrine. They do not always fund the mandate, which can leave schools in a lurch, or it's written in the law that it's mandated pending there is funding, and that if there's not funding, then it is permitted but not required.
Meaning the cost of the actual drug, training,
The auto-injector.
all of that.
Right.
All
Okay.
of that,
Okay.
right. Typically in the legislation, it is written how somebody becomes trained and permitted to use the device. And in all of the legislation that I have seen, anyone who is trained as described by however the legislation describes it, if they are trained and they recognize somebody or they suspect somebody in good faith is having an allergic reaction, then they are indemnified against.
Okay.
Yes.
So like a Good Samaritan provision.
But here's the sad thing. Some states don't have that.
So there's obviously hesitancy to use it in those states. If
49 states have stock epi legislation permitting the acquisition and use of stock epi in schools.
Okay.
Some of them are mandated, meaning they have to have it.
Sure.
Some states, they don't have to have it. It's permitted. But that is just K through 12 schools.
Is there? Now, let me ask you this. Maybe I'm wrong on this, but are there Good Samaritan laws directly attributable to stock epi use in the 49 states?
That would be, yes, that would be within the actual stock epi legislation is where you find that indemnification language.
So they do have that. So there isn't, and so in 49. Okay, well I did not know that. I thought there were states that might not have it. So all 49 states that have it also have indemnification. So there's really no reason why schools shouldn't take advantage of this.
True.
Right. Wow.
Okay.
Interesting.
Well, it comes down to a cost factor.
Cost factor.
Obviously.
Cost
Do they
factor.
want to have...
How much is a stock epi-pen? I don't even know.
Depending on the device that you're procuring, I know for a fact that AviQ is available for $246.99 through one of their distribution companies.
Okay.
If I'm a parent, right?
You want your school to have it.
I want my school to have it, just
Right.
like I want the AED, just like I
Correct.
want them to have the tools,
Right.
to be able to respond, not just for my child, but for any child. I mean, I think all of us sitting here in the studio would be devastated
Sure.
if one of your child's classmates didn't have something available.
That was $200.
That was $200, right? Now, some people, that's a lot of money. Well, I mean, you know what? When you think about it, is it worth that over some child having some severe injury or
Sure.
death?
I was speaking with a state trooper with this Safe Schools program the other day, and they focus on the intruder alert part of it, and that aspect of safety and having medical emergency or having emergency response protocols. But we both agree the least likely thing to occur in a school when you're comparing intruder, tornado, hurricane, and emergency and fire. There hasn't been a fire in a school for decades. Decades. Is it still very important we have fire drills? Absolutely. Is it important to have fire extinguishers? Yes, of course. But how many times is somebody having sudden cardiac arrest on a school campus,
Right.
whether it's a student or somebody coming in for Grandparents' Day or an athlete at a tournament? And how many of these kids have, or kids, not just any child, have a food allergy, or they're one of the younger kids who hasn't had their initial reaction yet, and so they don't even know they have a food allergy. They have a reaction. They don't have a device at school, and that's why, as this legislation continues to take through the country, I do think that 5-10 years from now, it's going to be looked at as a liability to not embrace this type of preparedness.
So let's talk about that 5 or 10 years from now. Okay, Codana, you mentioned that program, and we're both very familiar with that.
Yes.
So what kind of market penetration right now does Codana have in the United States? Where is Codana now involved?
We're across the country. We have education specifically for early learning centers, and we're doing a new train the trainer model where we're actually teaching child care health consultants how they can teach about food allergy in their early learning centers, daycares, preschools, and that's across the country. We have a very strong presence in New York, especially New York City, where our early childhood education for anaphylaxis, stock epinephrine in particular, is very popular. And then also in the state of Ohio, where I just came from, we work very closely with the Allison Rose Foundation. The young lady that I mentioned passed away at college. Her parents started the Allison Rose Foundation in her memory. And we have a course going live across the state next month that is going to be accessible for school staff to take. They get continuing education credit for it, and it's no cost to them.
So how many? I know we've gotten approved in other states too, meaning Codana. So how many states has Codana been approved as an official training program?
So what you're talking about is our stock epinephrine our stock epinephrine program being approved. States are tremendously different whether they even have an approval process.
Right.
So as we're going state by state, we've been very successful in the ones we've applied in, which so far is 12. Many of them, I think 13. We just got through to another one, because all the legislation is very different regarding how does training occur.
And is this? I'm sorry.
I'm sorry. We're talking. I'm sorry, Rory. So, because I like this. This is very. I'm very excited about this. I'm very passionate about it. So, in 5 years, you just said 13 states. Where do you predict Codana will be in 5 years?
In all the states.
So the goal is for you 5 years.
Oh, yeah.
All 50
No, we're
states.
actively working on it right now. And how we wrote the paper, The Heterogeneity of Stock Epi Legislation, that was published in Jackie in Practice, first author Maddie Oxford, my mentee in Pennsylvania, was because we were applying to get our Epi program approved. And the states don't always know how to do it.
Sure. Right.
But we found all that out because we're literally going state by state, finding is it Department of Public Health, is it Department of Education, and all the states are different.
But it's not just that, though. I'm sorry. It's not just that. It's what about the response plan? Do y'all just do, how does that fit in? I mean, the emergency response plan, I know you told me in the past about that. What is it? How does Codana help?
So you're talking about our Metairie program.
Right.
Metairie is a logistics program that teaches, and it can be done online. It's free of charge. Go to codana.org. It teaches schools how they can develop and implement their own medical emergency response plan, including a team for their school. They build upon their intruder alert, their fire drill. They build upon the protocols they already have in place, make a few adaptations using their crisis response team that most schools already have, and they practice having a medical emergency so that when, not if, when a medical emergency happens, they have a core group of adults responding quite promptly to that emergency with the tools they need, and they know how to use those tools.
So if a school or a private business, maybe we'll get out of the public sector for a second, but if a school or a private business is interested in having stock epi, like you mentioned, is that something that they could reach out to your nonprofit to find out about how to order it, how to get trained on it, how to kind of make themselves available to the protections and the Good Samaritan or the indemnification things? Is that something that they could reach out to you to navigate?
Yes, absolutely. And I'll point out that not all states have stock epi legislation for what we call non-school entities, meaning for businesses, for universities, for early learning centers. So here in Louisiana, we're actually working on some legislation to have that type of indemnification legislation so that any entity, especially our early learning centers, can have stock epi if they want it.
Interesting. I mean, I've watched this grow over the years. This is really, I got to say, Code-Ana and what you're doing is monumental for, I mean, I can't even tell you how many families you probably touched. You never know. I mean, if it helps prevent one death or one severe injury, you've succeeded.
Yeah, it's nice to get the emails from the school nurses, from the school principals saying, we did a drill or we had an actual emergency and we got to the child in 52 seconds. Or the emails about a Code-Ana trainee used stock epinephrine on a child and the child's doing great. Like, it's incredibly rewarding, but to your point, it's incredibly important work, and it needs to be in all schools.
So your nonprofit is able to go in, I think you mentioned before we started recording, to go into a school and kind of sit down with the faculty, or if they have a nurse or whoever it may be, sit down with them and kind of say, here are the signs and symptoms, and here's how to administer, here's what you need to do after administration, kind of everything from A to Z.
Absolutely. We first start with an assessment to really understand where the school starting point is, and from there we work with the schools to identify their goals and then provide education and guidance on how to achieve their goals regarding medical emergency preparedness.
But it's not just schools, though, you said. Businesses, too.
So we haven't done Metairie for businesses, but if businesses want stock epinephrine, if businesses have questions about AEDs for sudden cardiac arrest, those are things we absolutely can
You know
help
where
with.
I see this, Rory? Airline. In the plane. I mean, how many stewardess or stewards would you know how to respond to an anaphylaxis situation?
It's a very interesting discussion. We should dive down that rabbit hole.
AEDs is one thing, because I mean, you know, the AEDs, you know, you put the paddle here, you put it here, and you press the button, right? So, but I mean, imagine all the peanuts and crackers and all whatever that are served on planes. I mean, I can't imagine, you know, that would be an interesting situation, I would think.
So, Dr. Hoyt, where do you see the biggest need is for
That's a great
more
question.
of the stock epi? Is it schools? Is that where you kind of, is that like the big fish that you want to kind of encapsulate to get your dream goal is to have every school across the country, I'm sure, have this stock? Is that kind of what the
schools and early learning centers?
Okay.
Because that is where students might not have their own devices. That is where students might not yet have manifested their disease process yet. And it's not just having the actual device there that is incredibly important and teaching people how to use it, but it's also the secondary benefits that our society as a whole really gains from sort of demystifying food allergy and having everybody on the same page that yes, food allergy is real, yes, food allergy is life-threatening, and yes, epinephrine is the way you treat it.
Interesting. Well, I think we could go on and on Code-Ana. We could go on and about food allergies, but I want to think it's time that we try to wrap this up, because I think I want to continue to have you on for more episodes. I mean, I think we're going to have to, you know, do like a part series, right? Because I honestly think that this is a real thing. You know, Dr. Hoyt has corrected me over the years. I've watched this happen, and where before I was sort of, is this just a, you know, helicopter parents and all this, and oh, come on. I mean, I ate peanut butter and jelly as a kid. I mean, I had all over my face, nothing would happen. Right. But no, I mean, now I genuinely recognize it. I see it in other parents. I see it in kids. So I got to tell you, Dr. Hoyt, I mean, both private practice, family, and advocate on a nonprofit, you got yourself pretty busy there.
Yes. True statement.
So if someone, and to kind of wrap this up, if someone wants to contact you for personal reasons, you know, for their child, like you mentioned, for their clinic, or if they're involved with a school or a business that wants more information about your the Stock Epi program, what's the best way for them to reach you?
So they can go to hoytallergy.com, and that's going to go to my practice. The number on there is the number you call, and you're going to get Alexis. She's going to answer the phone. And then if you want more information about our advocacy, codeana.org, CODEANA, 1A like anaphylaxis.org.
Well, great. Well, I want to thank you, Dr. Hoyt, for coming in the studio today.
Y'all.
This has been fantastic, a very educational show today, and we want to thank you again. So we want you to come back. So
thank you. I should have y'all on my podcast,
We
Food
should.
Allergy and Your Kiddo.
there we go. We should do that. We're gonna go to Dr. Hoyt's podcast.
Well, we don't have to. Let's not wrap. Let's jump 30 more seconds. Tell us about your podcast.
Yeah, that's a good
I'd love
idea.
to hear that. Yeah,
what-
tell us what is the podcast about. I'd love to hear more.
It's called Food Allergy and Your Kiddo, and it's all about food allergy in children. And
Okay.
I started it when I was on maternity leave. I think Adelaide was 8 weeks old when I started the podcast.
Wow.
I love what I do. I love the knowledge that I've acquired and continue to acquire, and I just want to share it with everybody. And I know that in my small clinic, I can't share it with the world, but I get emails from Tennessee, Georgia, Ohio, like all these places.
Sure.
So if you want evidence-based, practice-proven information about food allergy, foodallergyandyourkiddo.com.
So that's great. Podcaster, advocate, nonprofit, private practice, and mom.
Everything.
Can you?
What do you do in your free time?
Right. What free time? Is that what free time?
I eat fancy king cakes.
That's
right.
good. There
All
we go. Well, Dr. Hoyt, thank you very much for coming in. Again, everyone, if you want to contact Dr. Hoyt, you've got the contact information for not only her private practice, for the advocate group, and now you know the name of the podcast. So stick around for another episode of Health Law Talk. This has been really fun, Dr. Hoyt. Thank you very, very much.
Thank y'all.
And thank you all you listeners. Again, if you want to drop us a line, send us an email, talk to us about episodes that you want to see or hear, please do so. And again, thank you for listening to Health Law Talk.
Thanks for listening to this episode of Health Law Talk, presented by Shahardi Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardi Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardi Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.